Thank you, Noel. And our next speaker is Rajiv Rimal. Thank you.
Good morning. I think this is a nice follow-up to what we just heard from Noel, because I think we'll be talking about a lot of the same thing, or I'll be talking about a lot of the same things, so it's nice to reinforce what Noel just talked about. Before talking specifically about risk communication, I thought I would put this in a little bit of a context. So we have environmental risks out there, right? And we do assessments of that risk. Part of that process involves things like probability theory. We do risk analysis. Based on that, we develop some communication efforts to communicate to the public. Here we might think about things like, how we disseminate information. There's a lot of communication theory that talks about how to effectively communicate that risk to the public. And we hope that that communication of risk leads to some perceptions of personal vulnerability. After listening to the Ebola crisis information, people may believe that they are more at risk. Here we worry about things like health literacy. Is there comprehension? Is there persuasion? And then finally, we think about how do we translate that perception to actual behavior change, because most of us in this line of work are really interested in finding out whether behavior change has occurred or not. And of course, as we've heard this morning, a lot of these processes are reciprocal as well. So it's not just a one-way street. So this is sort of the overall model that many of us work under. And what we often focus on, at least in risk communication literature, is that bottom part, which is how do I translate perceptions of risk to actual behavior change. Before that, we also think about how do we communicate risk information accurately so that people actually believe us, and what are some of the issues that are relevant there. So let me start with that for just a second. I think we can safely say that communication seldom falls into a social, political, or cognitive vacuum. That distortion is the name of the game, right? All we have to do to verify that is figure out why 538.com was so horribly wrong, why Nate Silver was so horribly wrong, and we had put all our eggs in that basket. Many of us did. I did. And the common term we hear is the echo chamber, that we are fabulous in listening to people whose opinions we trust, who think just like us, because it's uncomfortable to go beyond that. It's uncomfortable to hold a conversation with somebody with whom we disagree. And so the echo chamber really resonates with all of us. One way to think about that is that the risk communication that's put out there, because of the different media, because of the different density of the molecules, if you will, there is refraction, that what we see is not often what was intended. There are lots of cognitive biases that we are enormously good at in believing that we are not at risk. Otherwise, why would you build a $5 million home on the San Andreas Fault, right? There are all kinds of mental gymnastics we do to convince ourselves that, in fact, we're not at risk. We have prior experiences that distort that medium, that allow us to understand risk information in a very different way. There are, when people ask us to evacuate, we think about the potential losses. I can't leave my home behind, so therefore, it must not be as critical for me to leave. There are all kinds of cultural and traditional factors that distort that risk information as well. And finally, there are cultures and traditions, political beliefs. All of these factors act to refract the message as intended. And therefore, we end up with a completely different set of information than what was actually being said. On top of that, particularly when you're talking about crisis situations, we are dealing with a lot of uncertainty. And when people are viewing the information through that refractory lens, and you tell them on top of that, you know what, we're actually not quite sure, what am I to do? Minimizing this refraction in public health, in public risk communication, a lot of these things we've already talked about, but I want to come back to this issue of trust, which is also what my subsequent speaker, Dr. Turner, is going to talk about. Trust through transparency. I think that we've talked about that as well. Being open about the process. In the vaccination crises that we've seen, there's a very interesting study that talks about how people perceived that the people pushing the vaccination worked for Big Pharma. So that reduced trust, honesty, clarity about what is known and what is not known. That's absolutely critical to talk about, and we've talked about that this morning. And then building partnerships for collaborative opportunities so that the communities being served have a say in what is being communicated to them, how their feedback is being heard or not heard. And then let's go to that bottom part, which is how do we translate risk perception to actual behavior change? Because we have this notion that we put the accurate risk information out there, people will adapt. Well, not many do. So my team has been focusing on that part of the equation for the last about 10 to 15 years. And I want to talk to you a little bit about what we have found from that body of research. There are many ways to measure perceived risk. One way is to think about the dichotomy between susceptibility, how much at risk are you, and severity, how horrible would it be if you were to get that disease. And what we have often found is that those two things may not go hand in hand. In fact, so I've worked for about 12 to 13 years in sub-Saharan Africa in HIV prevention, and what we have found is that people who believe that HIV is very severe, it could kill me, I would be debilitated, I would be able to get to work, also believe that they are not at risk. So I work in Malawi where when we first started working, the HIV prevalence was about 18%. So 1 out of roughly 5 people were susceptible to HIV. And yet when we did extensive surveys about people's perceptions about how vulnerable they were, our risk, the perceived risk was in the magnitude of about 2 to 3%. So big mismatch. And you can say, well, you know, people don't really understand their risk. Maybe. But maybe that is how you get through the day. That if you've seen the devastation of HIV in your village and you've gone to many burials yourself, how horrible it would be to also believe that you are at risk. And so as a coping mechanism, we come to believe, you know what, I'm not at risk. I can't be. I can't allow myself to think that I'm at risk. There's also an increasing body of work that shows that how people perceive risk information and what they do with that information is really dependent on how efficacious they feel to deal with it. So let me talk a little bit about that. So we, in the context of HIV and many other diseases, we ask 2 questions or a series of questions based on 2 dimensions of the public. We say, do you think it's going to happen to you? How much at risk are you for this particular disease? And if it were to happen to you, could you do something about it? Or could you do something to prevent it? So that's the efficacy component. And based on that framework, we classify people as, you know, I'm not at risk, it doesn't matter to me anyway. We would classify you from a social marketing kind of perspective as being indifferent. You know what? Yes, it could happen to me, and if it happened to me, it would be horrible. And in that case, I'm not going to deal with it. I am that ostrich. I'm going to bury my head in the sand, believe that it's not going to happen to me, right? Yes, I could be at risk, but there's a lot of things I can do to prevent that disease from happening to me. I can use a condom. I can reduce my number of sexual partners. And we call, if you have that belief, we call you proactive. And yes, I live in a high HIV risk prevalence country. It could happen to me, but you know what? There's a lot of things that I can do. And in that case, we would call you responsive. And the goal of the campaign, the interventions that we've been running, is to get everybody into that bottom right cell. If you live in a high prevalence country, we want you to be responsive. Oops. Okay. Let me share with you survey data from, or intervention data from Malawi, where I've been working for about 12 to 13 years. Here's just a brief description of the sample. And before the intervention began, we asked people the same two questions. How much at risk are you to HIV? And is there something that you can do to protect yourself? And what we found is that, as you will see, the black line at the bottom, the dark line, is people who have very low sense of personal efficacy, low sense of personal control. For them, increasing risk, lowering risk information does not really make much difference. In fact, there's a slightly downward tilt. For people who have higher levels of efficacy, yes, there's a lot I can do, then higher levels of perceived risk is actually, on the y-axis here is their intention to engage in healthy behaviors. That's actually productive, not counterproductive. At the end of the campaign, at the end of 9 years, here's where we ended up. And that is that in the, over here, the indifference, this is, it's not going to happen to me. I don't care. There's nothing I can do about it anyway. That group decreased from 60% over the 9 years to about 15%, which is exactly what we would want. Over here on the responsive side, which is what we want, where we want to push everybody, we started with a group that was what, about 3 to 4%. At the end of 9 years, they were at 40%. So we were able to push people into that category. Second question, did it matter? Pushing people into that category. And here are results of people in the indifference category. No problem, no solution. Lots of problems, lots of solutions. And in fact, if you have high efficacy, which is these two bars, your condom use was significantly greater than if your efficacy was low. Same thing with being tested for HIV. We see the same pattern, that if you had higher efficacy and you also believed you were at risk, the likelihood of your testing for HIV was much greater. So pushing everybody to this cell helped translate people's perceptions of risk to actual behaviors. And finally, self-efficacy is probably the more reliable predictor of behavior. Across behaviors, there's a ton of literature to show this. So it's not a matter of just getting people to feel scared. It's a matter of informing people what exactly they need to do to take control of the situation. Feeling efficacious, that's a wonderful basket in which to put all your eggs. Thank you.